For a conversation on reprogramming tumors, please welcome Dr. Caron Jacobson, the Medical Director of the Dana-Farber Cancer Institute, Judy Wilkins, a cancer patient and owner of Scruples Hair Salon, and Tim Moore, Executive Vice President of Technical Operations for Kite, a Gilead Company. Back to lead the conversation, the Atlantic's Alison Stewart.
It already fell off.
Good, you're adjusted. These folks have been talking so much backstage. I almost don't need to be here for this conversation. They've been having such an incredible one. I'll just sort of try to get out of the way a bit. Judy, you are the owner of Scruples Hair Salon and a stylist.
I am.
You have incredible energy. I saw that backstage. But there was a point when you must have realized something wasn't right physically. Do you remember when it was you really began to realize, I'm not well?
I do, yeah. Total denial, though. I just, yeah.
When was that?
It actually was in 14, the fall of 2014. I was diagnosed in November with non-Hodgkin's follicular lymphoma. I felt all right, though, at that point. I'd had a staph infection before that. And then my lymph nodes just stayed in the emergency mode. And at that point, they wanted to start treatments, and that's when we decided to get a second opinion and come into Dana-Farber. And that's when I met Caron in January. Yeah, it was actually 2014, so it was 13, November 13, sorry, yeah.
And how was it described to you before you met Dr. Jacobson, what your options were?
They really weren't giving me options. When I was diagnosed, I had a lump under my arm, and they had done a biopsy and came back with the follicular lymphoma, and they were actually going to start chemotherapy immediately and do another biopsy. And I just wasn't sure, and speaking with my husband and other medical people, that, you know, time to get that second opinion and go to the scary place, Dana-Farber.
It's not scary,
no,
right?
No.
When you first met Judy, Dr. Jacobson, tell us a little bit about that first meeting and the first encounter and your first thoughts about, wow, this might be somebody that we could work with on this CAR T-cell. Yeah,
well, this was long before CAR T-cell therapy really was available or was in clinical trials across the United States. So when I met Judy, she had a slow-growing type of non-Hodgkin lymphoma. It was fairly low volume. She was feeling great, and actually, we often observe patients like that for quite a while before they need therapy. And it's only when the disease progresses to the point that it needs treatment that we then entertain some, fairly traditional chemotherapy approaches. And so Judy started to come to see me every 3 months. For the next, 2 years, I would say, 2.5 years?
2 years, yep.
And then one day she walked into, and obviously entertaining me the whole way. And then she came into my office one day, and she was not herself. She was really, really sleepy. She was very lethargic. She wasn't joking. She wasn't animated. And she was with a friend, and her labs came back, and I realized what had happened was that her calcium level was super high through the roof, and that was causing her to be so fatigued and run down. And when that happens, when someone has a slow-growing lymphoma, it often indicates that they've transformed into a faster-growing lymphoma, which is not something we sit on and just observe. That's something that we try to treat right away. And so we did some. Judy really didn't want to come into the hospital, so we did some maneuvering in the clinic over a couple of days and got her calcium levels back down, and then we started her on classic chemotherapy, which for this type of lymphoma is called R-CHOP, and it's given over the course of about 6 months. And Judy would have these responses that just, with most of the disease would go away, but there would just be 1 or 2 stubborn lymph nodes that would just not go away at the end of treatment. And so we had to do a second round of chemotherapy after that, and again at the end of that chemotherapy, which was another 6 months, there would be some stubborn lymph node that just wouldn't go away. And then we had actually transitioned her, this was all we were all hoping to get her to a type of stem cell transplant where we use her own stem cells, but if the lymphoma doesn't go away, we have to abort that plan and go a different route. And she had just started an oral, more targeted therapy when the slot came up on the Kite CAR T-cell trial that we were running. And Judy fit the eligibility profile perfectly because it was really for these patients who had chemotherapy refractory lymphomas, transformed follicular lymphomas. And so Judy took the spot, and she can tell you more about her experience at that point.
Well, Judy, when this was first presented to you, going into this trial, how did you first respond?
No.
No. What was it about? What brought the no on?
Research, not knowing, and I was afraid because I knew where I was health-wise. And I remember saying to Caron, now what are we going to do? And she's like, we're good. We have this CAR T cell. I'm like, what the heck is that? And then she explained it a little bit to me, and I'm thinking research, and I don't want to do this. And then she told me some of the side effects of brain swelling and death and bad flus. And I thought, no, you know what, I think I'll just wait for the next one. I'm not doing this. And then Caron explained to me that, we really didn't have many options at this point. And she had the slot in this research, and that I needed to do it. So
not needed to, highly recommended.
highly recommended.
Yeah.
Doctor, when you have a patient like Judy, who you know would be a good candidate for this kind of trial, but who is reticent, who is nervous, how do you go about bringing them to this decision, which could really help them, but feels wrong to them initially?
Right, and so I think you just go about it by continuing to educate them and get them to see it, get them to see it with all of the information that you have, make sure that they're not looking at it from a limited data set or a limited amount of information. And so, luckily with this trial, we had already had quite a bit of preliminary data about the Kite product. It was in clinical trials at the National Cancer Institute, and then we already had some early data that had been reported publicly on this trial. So I was able to sort of educate Judy about, how effective it was, how many patients who hadn't responded to any prior therapies achieved a response. So on the trial, it's over 80% of patients respond to it, and over 50% of patients have a complete response. And so I could give her that data. And then also we had a lot of experience with the side effect profile. So while yes, there are some real risks with CAR T-cell therapy, the risk window is actually this very finite period of time that's really in the first 2 to 4 weeks after the therapy. And 99.5% of the time, it's a reversible toxicity that gets better on its own that we just have to support a patient through. And if you remember, Judy was looking at stem cell transplants before that, which is 3 months to 12 months of infectious precautions and things that were going to remove Judy from her livelihood. And so reframing the conversation and making sure that she had all of the information she needed to make her own decision, which is obviously the most important part, was part of the ongoing discussion.
Tim, I'm going to bring you in the conversation. We have a room full of medical professionals here in Boston who understand what CAR T-cell therapy is. For people who are watching online or the internet, or just Google this one day and it comes up, will you explain the process for us?
Sure, I can do that. But before I do that, I just want to say how lucky I feel and inspired I feel to be with these two ladies here.
Thank you.
Today.
Me too.
It's just amazing to see a patient and somebody who helped that patient get great treatment.
Thank you.
So thank you.
Thank you.
So CAR T, it's very complex process. However, we are seeing great results, and it's where we take a patient's cells, we isolate the T cells from that, because obviously when you collect cells through leukapheresis, you don't just get T cells, you get lots of other cells. And you have to isolate the T cells. Then what you do is you activate those cells, get them excited, and then we genetically modify them by using a transduction. And that's where we genetically modify them so that now the T cells will recognize the tumor when they go back in. You then grow the cells back up to get to the dose level that's based on the patient's weight. And we dose at 2 million cells per kilogram, up to a maximum of 100 kgs is the max the dose would be. And then you send them back, and they're reinfused in the patient once they've been pre-treated. They are pre-treated before they get infused.
walk us through the timeline of the process, from when it starts to when the cells are delivered to when they go back to the patient.
Yeah. So we feel we're pretty fast at what we do. Of course, it takes a day to get the cells. It takes us generally around 14 days to not only manufacture, which is in the 7 to 8 day range, but also then you need to do all your quality control testing to make sure everything met its criteria, and then ship it back. So end to end, 17 days on average.
Wow.
Yeah.
17 days.
So Judy, what was going through your mind during those 17 days?
Well, in the very beginning, I remember when they put the cells back into me, you get all excited, okay, just a quick infusion and it's over. And then I remember calling Kathleen, saying to her, like a day and a half later, I think something's wrong. They put the wrong cells in me. Nothing's happening. I feel fine. I just wanted to go home. And then Caron, they had called Caron and said, no. And then after the 48 hours, then it started to take effect, and I got really sick, and I got very excited about it because I thought, okay, this is great. It's working. It's finally working. Yeah. And then from there, it was, put a road, a week of being very sick, being monitored very carefully.
So, but in the interim between when we collected your cells and the cells came back and, and you got them back, were you anxious? What were you?
A nervous wreck, yeah. And then I worked that whole week because that's the best thing. Did you really work? I did, because that's the best thing for me.
How were the cuts? The haircuts work out okay?
Everybody left with 2 ears. But it was just better for me to be with my clients and talk to them. And till I had to come in, I had to do a couple of days of chemotherapy so that they could put the cells back into me without being rejected. And that's when I had stopped working, was the end. And at that point, it was just everything going through my mind, Am I going to be okay? Am I going back to work? Am I going to be out of the hospital? But,
Doctor, what do you... Go ahead.
I was just going to say, and I can guarantee you we wouldn't infuse you with somebody else's cells because we identify the chain of identity and then track the chain of custody end to end. So that is a critical part of the process.
Yes.
And
it is absolutely essential.
And I would point out that Judy's ability to work during those 14 or so days is unusual. So many of these patients have a lymphoma that has not responded to their prior therapy and is progressing, and these are fast-growing lymphomas. So lots of patients are actually very sick during that window. And we're working really, really earnestly to try to help them, to control their symptoms and help them feel as good as they can during that time, and also prevent them from, not being eligible to get the cells 14 days later. So in that respect, the one silver lining for Judy was that she felt good that whole time and really didn't require a lot of intervening, finessing of her care to get to that point.
I was going to ask, once a patient has the cells introduced, what do you as a doctor, what are you looking for?
Yeah, so we bring the chemotherapy is done as an outpatient. It's 3 days of chemotherapy, and it's given to help, as Judy said, not to reject the cells, but also to help the cells expand maximally once we give them back. And they come into the hospital 2 days after they finish the chemotherapy and get the cells the following day. And on the trials, and then also we continue this practice using the now FDA-approved commercial product. We make the patients need to stay in the hospital for 7 days of observation. And that's because of the two main side effects that we see from CAR T-cell therapy, one being cytokine release syndrome, which can happen as early as 12 hours after the infusion, but most of the time happens on the second or third day, and can last for anywhere from 3 to 5 days, or sometimes even longer, which for most patients is a high fever and flu-like symptoms, but in extreme cases can cause low blood pressures or difficulty breathing or difficulty with kidney function or things like that, which often require higher level, more intensive care. And then the next side effect profile that people can get is this neurologic toxicity, which usually happens around the time that the cytokine release syndrome is actually improving. So it kind of it takes off around day 5 or 6, and then can last for anywhere from 3 to 14 days. It can be a very long period. And so we feel like if we follow people during that 7-day window, we wouldn't send anyone anyone home who was having either one of those side effects around day 7. We'd wait for those side effects to abate before we were able to send them home. So Judy was able to go home on day 9 or 10, but most of our patients stay for, on average, for about 14 days for both of those side effects to abate. But, they, as I said earlier, the vast majority of the time it's totally self-limited and reversible, and people leave the hospital, with all, thinking as clearly as they did when they came in, and without fevers or ongoing inflammatory symptoms.
And how was your experience after, once you walked through the part when you said, yay, I'm sick, because they're fighting, the cells are fighting?
Then every day I just wanted to go home. They did all the tests all the time, the neurological and all that. And I remember saying to all the fellows that I'm leaving on my target date. I'm getting out on the 9th. And have you talked to Caron? I'm like, no, not yet. And I ended up getting out on my target date, which was great. And then the month of August, I was pretty much in bed the whole time, tired. I mean, I could sleep. I think I slept almost 20 hours without just getting up, and Kathleen would check in on me, and friends would check, just to check my temp every few hours in the beginning. But every week I felt better. And I remember thinking to myself in the 3rd week, how am I going to get up and go in for this PET scan next week? I can't do that. And then that next week came, and my PET scan came up, and still weak, but I got in, got my PET scan, and 100% remission 4 weeks out, and that just gave me like, woo. Wow. And then I remember saying to Caron, when can I go back to work? And she's like, it's up to you.
And you had never been in remission at all. So that was enormous.
No, I couldn't get there, no. Wow. And I'm almost 22 months out now, 100% remission. Yeah. Thank you.
Awesome.
Yeah.
Tim, Judy sounds like she was a perfect candidate for this, but there are people who can't be or won't be. Who isn't a candidate for this?
Well, I'm not the doctor.
No, Dr.
So I might defer to the doctor. But clearly in our clinical program, we identified patients that are eligible and not eligible for that. I will say this therapy, as it falls off, this therapy is in the beginning. So as we learn more, I think we're going to learn more about what patients are even more eligible or not as eligible over time. But maybe if you want to provide a little insight into the patients that aren't eligible.
I think that sometimes people think about clinical trial data and they think, oh, well, that was a really selected group of patients. And yes, there are some refinements to who's eligible and who's not, but I think you have to remember that this is a clinical trial that took the sickest of the sick, at least in what I see. I only treat lymphoma, and these are really sick patients. So, the one thing that that really does select for these patients is what I had referenced earlier, which is that it's these are patients who have to be able to wait for their cells to be manufactured. And on the clinical trial, they had to wait for that without any intervening lymphoma therapy, because the point of the trial is to see how effective this therapy is at treating the lymphoma, and not to mistake it with whatever therapies they might have gotten in between. So, that is the rate limiting factor, I would say, for most patients. I mean, we do, because of the stress of the inflammatory response from the T cells on the body, we do require and still require a certain, a minimum amount of heart function, a minimum amount of renal function, or kidney function, and a good respiratory status. Those are all things that are important, and I think we'll learn with time, whether we can liberalize that. But really, it's about the pace of someone's lymphoma and whether they're going to be able to, whether they're going to be able to stay healthy enough during those 2 weeks, 2 to 3 weeks, for their cells to be manufactured. And the beauty of now having a commercially approved product is that we can give some intervening therapy while we wait for the cells to be manufactured. But of course, we're not sure that therapy is going to work. We're also not sure those therapies often have other side effects, and that could jeopardize a patient. So as a physician, we're always walking a fine line, but really trying to make this as broadly applicable for patients who are not responding to chemotherapy with lymphoma as possible. Yes.
I'm going to open up to questions in just a moment. Every article you read about this, every news story, it mentions the cost, $375,000 to $400,000. What are we going to do about that?
We are always trying to improve our operations. And it's not just with our current, yes, CARTA, but we're in continuous productivity improvement on new platforms. It's no secret out there, there's a lot of us are also looking at allogeneic, which will obviously improve costs versus this truly personalized medicine. So bottom line, continuous improvement to improve the cost structure and drive to the next platform. You know, because again, to me, cell therapy, we're at the beginning. This is a new platform, new technology that I think is really, over the next 5 to 10 years, is going to take off and do amazing things for patients. Not just in the diseases we're treating today, but when we get into solid tumors and things like that. I'm really excited.
It's interesting. Yeah, every article also has a sense of optimism about it when people write about this. Why is that?
Well, look at the clinical results. They're amazing.
It's working.
They're amazing clinical results when literally you're dealing with patients that really don't have any shot on goal left. And they're, like you said, a lot of them are on their deathbed. And the results we got were just phenomenal.
We don't have any long-term observation though yet, right?
Well,
it depends.
So on this study, but on this study, the follow-up, the median follow-up that's been reported was over 15 months, and for this disease, that's actually quite a long follow-up. You know, for any other therapy with this disease, most of the relapses happen within the first 2 years, but most of the relapses happen within the first year. So getting to 15-month follow-up and seeing that there's this plateau in the patients who have responded that are maintaining their response is actually quite remarkable.
The length of time,
yes,
within context.
We need more time, but it's still 15 months is actually a notable amount of follow-up for this disease.
And that could continue to grow. We haven't hit an endpoint yet.
Okay, great. Do we have questions from the audience? We've got a gentleman here.
Say your name.
Nisarg Patel, a student at Harvard Medical School. Given the very intensive monitoring for patients who undergo CAR-T over the first few weeks of their treatment, do you ever see this being used outside of large academic medical centers?
So it's a great question, and I know that Kite has done this very systematically, where they, rather than just expand maximally at the beginning, they're doing a very slow rollout and starting with centers that had familiarity with the product or with CAR T cells in general, and then moving out. I think that the issue is that right now, especially with the autologous CAR T cells, you need to have a center that has a way of collecting the cells. So they have to either have a pheresis center on hand, or they have to have a relationship with the Red Cross to do their pheresis. And they have to have some sort of cell manipulation facility to receive the cells back and be able to thaw them in a safe way. So that is selecting certain centers from the get-go. But I do think that despite the fact that there is this toxicity profile that you need to monitor, it is very stereotyped. And I think if you can get over the logistics of how to collect and receive the cells, and then you can be trained in how to manage the toxicity profile. And I think this can be more widely accepted, be more widely used. I think the less the question of community centers versus academic centers, but more the question of, does this have to be at a transplant center, or can this be in a non-transplant center? I think it can be. I think it still needs to be someplace that that has a robust clinical platform. But I think you could see moving this to places that are not transplant specialized centers.
We have time for one more. Anybody? Right here. They're going to grab microphones coming to you.
Hi, good afternoon. Andrew Paolini with Pharma. I had a question for Dr. Jacobson. Just from a personal standpoint, what does it mean for you having another tool in your toolbox, whereas before you might have to give someone some pretty devastating news, and now you've got something completely new that you can bring to the table. I just personally would love to hear what that has meant to you.
Yeah, so this is, I think that many people work their whole lives in medicine to be able to participate in something or be part of something like this, and I feel very fortunate that I got to be part of it so early in my career. I don't know that it'll be matched, Judy was healthy at the time that we gave her CAR T cells, but her outlook was not good, and as she said, we already were starting to have some difficult discussions, and there were many patients who you could be having the conversation of, you could go to hospice or we could do this CAR T cell therapy. To be able to help all of those people and to be able to offer them something, some hope, and to see the tremendous results. I mean, to see people back at their livelihoods. I mean, the question of cost came up, and Judy was back at work 6 weeks later. Yep. She's working full time. She had a grandson, in February. Her life is taking off, and to be able to restore people back to that livelihood, it's unmatched. There aren't words to describe it helps me wake up and go to work every single day. Yeah.
Our clock ran out perfectly at that moment. Let's thank our panel.
Thank you.
Thank you.